Hey everyone, I'm Travis and this is Abby. And welcome to Concussion, the podcast that dives deep into the world of brain trauma, breakthrough treatments, and inspiring recovery stories. Let's get into it. All right, what's up everybody? Today we're going to be talking and covering the new way to diagnose concussions.
So I'm Abby.
I'm Travis.
And thank you for joining us. We're going to go through exactly as Travis said. How do you know if you've had a concussion? How does the healthcare side of things look at diagnosing a concussion? And it kind of ties in perfectly to what we discussed last week regarding myths about concussions. Because a lot of times folks feel as though there's a test or something that would indicate I am concussed or I am not. Right?
Like a clear definition. You are concussed, like one of the eye charts that a doctor uses.
Or like even like, do I have the flu or don't I? We have a test for that.
Okay, you know? Gotcha.
Like something that would give you a yes or no. Do you have this or do you not?
Gotcha.
Yeah. And the reality is there's not really something along those lines. And I think it's important that we talk about this in the realm of the realistic healthcare setting, meaning like what's available at Stanford University only, or what's it available at this premier hospital that specializes in brain trauma. I think it's important that we talk about this in a day-to-day. You live in a small town, you live in a medium-sized town, or even sometimes in a city. What would happen if you think you have a concussion and you decide you want to go get it diagnosed?
Right, because people in small towns, like it's going to take them longer to get all the info, all the latest and greatest technology.
Yeah, and especially if some of that technology requires special equipment, special training, it's not going to really penetrate that well into all areas of our country versus just some areas that might be doing clinical trials with different things or just have access to certain things other areas may not.
Right, because we know from last week, it takes from anywhere from 10 to 17 years for the information, once it becomes found out, once they figure it out, to even get implemented across the full spectrum of
healthcare. Exactly.
Yeah.
Exactly. So we already have that gap between when something's figured out and it changes the way we do things. But then technology is another barrier, training, implementation, all that. So we're going to talk about this in the context of if you are in a traditional community, average town in the US, what would happen in terms of the diagnosis side? How do I know if I have a concussion? And we're going to start back to something that's still used today, but is really outdated in terms of concussion assessment. But this was actually in place when Travis had his concussion, the Glasgow Coma Scale.
The Glasgow Coma Scale.
So that is, I think it was developed back in the 1970s.
1970s.
And it looked at very rudimentary function of the brain. All the criteria here goes through eye-opening, motor response, and verbal response.
Motor response, like how well do you respond? Can you squeeze my hand? Can you?
It's a good example.
Can you? Do you know what your name is? Can you talk? Can you focus on me? Are you awake?
So the eye-opening part, it'll break it into: can you do it? Can the person do it on their own? Is it spontaneous? Like if they hear a noise or somebody walks into the room, do they open their eyes? Okay. And then if they don't do that, would they respond to a loud voice? Okay. So if somebody comes up to you, speaks very closely in your ear very loudly, do they respond to that? And if not, then to pain.
To pain.
Oh. So if they squeeze the nail bed or do a sternal rub, yep.
Poke you in the foot with something like who knows?
And see if the person opens their eyes.
Hold a lighter under your foot. No, they don't do that. They're not doing that. They sternum rub is probably one of the
sternal rub. Yeah, that's something. So they just take their knuckles and kind of dig into the bony prominence in the center of your chest.
The first time I learned about the sternum rub, we were talking about that at the lunch table at work, and I knew we were talking about medical professionals, and I did that. I took my knuckles and I went like that, and I was like, oh man, like yeah, you could really wake somebody up like that if they were just pretending.
Yeah. So there's no muscle there. You don't really accumulate a lot of fat there. So it's just a very prominent bone. So yeah, if you dig your knuckles into that, it'll get you to open your eyes if you're able to open your eyes.
Yeah, for sure. You're not gonna pretend like you didn't feel that.
Right. That's a hard thing to not to not have a reaction to.
Yeah.
So depending on your response to that, so if you don't open your eyes in response to pain, then it goes down to the lowest scoring, which would be a 0 there. So it'll rate just in the category of eye opening if you do it spontaneously, to noise, to pain, or if there's no response there.
So basically, the higher the number, the better you are.
Yes.
Gotcha.
Yep. So no response at all, 0. Spontaneous eye opening, 4.
Gotcha.
Okay. And then the next one is the motor response. So that means that you gave the example, squeeze my hand.
Squeeze my hand.
So you could not be opening your eyes, but you could follow motor commands.
Okay.
Okay. So if the doctor comes in, and then it's tough with brain injuries because sometimes there's a palmar grasp reflex that will kind of reemerge if it's a more severe brain injury. Okay. So usually the motor commands, they'll even give something a little bit more complicated, like raise your arm, wiggle your toes, something that's more volitional, just because sometimes the stimulus of putting something in the palm can cause,
automatically grip.
That's a primitive reflex. So for babies, if you put your fingers in their palm, they'll squeeze your fingers, and people will think like, oh, this baby must really like me. Like, no, that was...
Yeah, that's just
it was not a choice.
That's a natural reflex. The baby probably doesn't like you at all.
Right. The baby would squeeze a lollipop too. Anything that goes in their hand, they'll have that response when they're young. So that motor command part, like I said, sometimes they'll give them something a little bit more volitional, like wiggle your toes or raise your arm. So that has a similar feel to it, where it's going down to the best being a higher score, and then it works its way down to localizing pain with a motor response. So if I were to pinch you or do that sternal rub, if you have a motor response towards the area that we inflicted the pain.
Okay.
Okay. So that's one step down from being able to do it volitionally. So being told to do it and executing it. And then the next level down is if you withdraw from pain.
I gotcha.
So if I squeeze your nail bed in your finger and you pull your hand away.
No, that didn't hurt. That's okay. It didn't hurt.
But if you're laying there still and somebody squeezes the nail bed,
I gotcha.
then if they pull their hand away,
yeah,
that'd be a motor response to that.
Okay.
And then the next one down is abnormal flexion posturing. So to give you a preview of what's after that, it's abnormal extensor posturing.
Okay.
Have you ever heard that before, that somebody's posturing after that? Yeah.
So, but it's like, it wouldn't be anything to do with like a coma. Like, oh, he's posturing. Like, I'm just kind of like maybe showing off, maybe like showing out.
I haven't heard it used that way. That's good to know.
Well, he's like posturing, or like he's being aggressive.
Okay. That's good to know that's something that would be used in that context.
Yeah.
So after someone like is in it, oh, you're good. After someone is in an accident or takes a hit, something we're keeping an eye out for is if they start posturing.
Okay.
And what's meant by that is they would either go into decorticate or decerebrate posturing.
Okay. What does that mean?
So decorticate is when their wrists are flexed, their elbows are flexed, and they kind of come in like this.
Okay.
And that's a posturing that indicates there's an injury to their brain.
Okay.
And then there's a decerebrate posturing where your elbows go straight, you turn outward. Yep. And it'll be alongside your side.
Oh, so I mean, you could go into that, like maybe if you were like going into a seizure, something like that, like you
start posturing.
Yeah,
yep.
You start posturing.
So it's like an involuntary thing where the muscle tone is taking over to control the position. So the person's not choosing to be in that flex position or that extended position with their upper body. It's more so a reflex or a response.
Okay.
To the insult to the brain.
I gotcha.
So another example of that doesn't fall into the Glasgow Coma Scale is sometimes for football players, after they take a really hard hit, you'll hear commentators or medical professionals saying he's going into a fencing posture. So in a fencing posture, they tuck one arm, straighten the other one, and turn their head towards the one that's straight.
Okay.
So that is another example of a reflex that's present in infants that can reemerge after a hit to the head. So those are the posturing examples.
Gotcha.
And then the last category for the motor response is no posturing at all.
None.
Be flaccid. Yep.
You're done.
Yep. So like the doctor could put your hand on your belly, your hand's going to stay on your belly. You're not going to engage any muscles to change that position. Just no motor response at all.
Gotcha. And this is the Glasgow Coma Scale. This is like how they're going to rate you. And so what are some of the problems with that? Because I mean, that all sounds good, you know?
Yeah, so the last category is the verbal response, but it goes through that same thing. Like if the person's oriented, they score high. And then if they say words, but they're not used appropriately, then that's another level. And then level down is incomprehensible words or no words. So this was, like we said, developed back in the 70s. And it was a way to quantify what happened when someone hit their head. If you think about it, if you work in a hospital or an emergency room and somebody's coming into you after, let's say after a car accident, you need to have some way to quantify somebody who's just confused but moving versus somebody who's not moving, not responsive. So this developed over time to start giving scores or criteria to what happens after a brain injury.
Okay.
But as you can imagine, I could score very high in all three categories
And be completely messed up.
and still have a concussion.
Yeah.
So it does fall short for the concussion side. It does a good job of setting up what's called clinical trajectories or prognosis for
Okay.
someone after they have a severe brain injury.
Prognosis, and that's
So,
like
like,
what's going to happen.
Exactly. So it's going to predict, is this person going to regain consciousness, or they're going to be somebody who walks and talks and does all their normal things within a certain period of time, or is this looking like this person is going to be dependent on ventilation for
ever?
Yeah, exactly. So that's what that tool was meant to do, to be able to classify and set expectations as to how well that person would do in the future based on how they present after their head injury.
And for one of the reasons that we need a new scale is because sometimes there are people who present not well, but then they end up becoming well.
Yeah. So I think to tie this into your scenario, I think your Glasgow Coma score was probably 4 or 6 when you first came to the hospital.
Yeah. So I was like, I don't know. So I was sedated. Like I know that they had put me, like they put a tube down my throat and all that.
Yeah, you were intubated. But I think you were responsive to pain. You weren't opening your eyes. And I can't remember the verbal response, because I know we talked about at one point you saved all those records and everything.
Yeah.
But all to say that you scored very low on your Glasgow Coma Scale, but you outperformed that prognosis.
I did.
Yeah.
I am an outperformer.
Yes.
Like
You're walking, talking, working, everything with the same precision that you did beforehand.
Maybe even a little better.
Maybe even a little bit better. So that's all to show that that's an example of how that Glasgow Coma Scale fell short of a true clinical picture.
Right. Because according to them, like it was
Not looking good.
not looking good.
Right.
And now I'm building podcast studios and refinishing the basement.
Exactly.
Yeah.
Building fountains.
Well, yeah, putting fountains in for the wife.
Yeah. She brought up a good point. I asked her, why are you throwing coins into your own fountain? And she said it's because the copper is supposed to keep the water in good clarity.
Yeah. And the algae out.
And the algae out. So we think that at these big malls, somebody just randomly started the trend of throwing pennies in there and making wishes.
Yeah.
Just to get people to keep the water clean in those big fountains.
Yeah. That's crazy, huh?
Yeah. This whole time.
Yeah.
That was just a preventative measure for the maintenance crew.
Yeah. It was copper ceases algae growth.
Yeah. How about that? So if you're in that scenario where you personally had a Glasgow Coma Scale, that would indicate that you were not going to do well long term, and then obviously did very well long term. And you hear a lot of stories in the news, like 2020 episodes, Dateline, where they're talking about something horrible that happened to somebody. And almost always in those types of shows, someone will mention, the doctors told me I would never walk again.
Yes.
And then the person's probably competing as an Olympic athlete in that story. Probably because they were using this Glasgow Coma score to create that prognosis. If they didn't have any motor response when they came in or scored very low in all that criteria, that gave the doctor that reason to make that prediction or prognosis based on how they would do. So,
unbeknownst to even the doctor,
right, that this person would walk again.
Yeah, because they're just going off what they know. And we talked about on a previous episode that doctors don't know everything.
They're really good at what their discipline is, but that doesn't mean that they have to be an expert in everything. So finding the right expert for what's going on with you is very important.
Right. You can't know everything about everything unless you're one of the guys at my work.
They know everything there is to know about everything.
It's crazy.
Yes. Thank goodness you work with such experts. You don't have to spend any time curious.
I'm blessed. They tell me everything.
So from that Glasgow Coma Scale, things have evolved in terms of what we can understand about what happens in a traumatic brain injury that outscores a Glasgow Coma Scale. So meaning that the person is able to speak, they have appropriate motor responses, they can control their body. And again, this is just testing something simple. It's not stand on one leg with your eyes closed. A motor response is pick up your right arm and then have spontaneous eye opening. Doesn't say anything about how well the eyes move. It's just if the eyes are open.
Gotcha.
So within that now massive gap of this person is not in a coma, but they did injure their brain, how do we get an idea about how this person is doing currently and how well they're going to do? And what got your interest was you found that there's now starting to identify biomarkers.
Biomarkers, right.
And biomarker is just a term for something that's exists in the body that could give an indication.
A biological marker, like a indication in your blood.
Yeah, but it doesn't even have to be your blood.
Like your spit or your bodily fluid.
Or it could be on an exam, like an image. So a biomarker would be anything that exists in the body with a clinical connection.
Okay.
So in the one that you found particularly, they were talking about a biomarker being evidence of bruising or bleeding on a CT scan.
Okay.
And the point of the article was that now medical institutions are taking into consideration that there's far more detail that needs to be incorporated to make an accurate prognosis or an accurate care plan for this person. So, for instance, has the person had a concussion previously?
If you get a concussion, if you have a concussion once, does that make you more susceptible to your second concussion?
Yes.
So if you've had one time, then the likelihood of you having another one is greater.
Yes. And it could also mean that they would interpret some of those findings a little bit differently. Because what if somebody had a severe concussion and had some sort of impairment that was never addressed and they continued living with that impairment? And then they have another head impact. What if what they're assessing in front of them was truly from the first one?
Yeah. They just never called it.
Yeah. So that's a really important thing to consider. There's also considerations of psychological status. Is the person currently being treated for bipolar, anxiety, depression, all things that would affect how you would heal or cope with a concussion. And then also looking at different aspects in terms of function. So as we mentioned, the Glasgow Coma Scale was just, can you open your eyes? Not how well can you move them? Same thing for the motor response. Can you move your arm? Not how coordinated are you with moving your arm?
Right.
Or how coordinated are you with walking?
Just can you move it?
Can you move it versus how well can you move it? So that's the exciting part, that it's kind of moving in that direction of looking at a much more comprehensive view, because they pointed out that if we don't start making assessments fit the reality of the symptoms of a concussion, people will go years, if not decades, without getting these symptoms treated. So the diagnosis part is oftentimes the most critical piece of the puzzle. In other words, they're saying, if no one ever tells you you have the flu, you're not going to take flu medicine or something else that would require a specific medication to address the symptoms of that. So that's kind of the neat part of where things have evolved to now, of recognizing a much more comprehensive view, and then also taking indications from the body. If there is evidence of bruising, bleeding, swelling, all of that help create a clinical picture of biomarkers and specific symptoms.
Gotcha.
Yeah. Now, your instance specifically, there was no point in which any doctor said to you for the first few years that you sustained a concussion.
Say that. What do you say that again?
In your scenario, there was no point in the first few years.
No point. Yeah, right. You're right.
That someone said to you, you have a concussion.
Right.
So that diagnosis wasn't there. So there was no need for you to pursue a treatment for something that was never diagnosed.
Right.
And then 9 years later, there's this realization of this is something I've been living with. Now I want to have it treated.
Right.
So it's almost like you have to backtrack something that just went unidentified for so long.
Right. Yeah. And I'm trying to think of a good metaphor to put that into perspective. It's like, let me think of something. If you hear, say, a wobbling on your car, you hear this weird noise on your car and your tire falls off. And maybe, it was because you didn't tighten your lug nuts up. Maybe not. I don't know. I can't think of a metaphor right now.
Yeah, it's hard to come up with a good example because the part that's so unique about the concussion is, as the Glasgow Coma Scale points out, you could do everything in isolation fine. From the outside, you can look fine.
Mm-hmm.
But when things have to be multitasking or multifactorial, like balancing emotions and taking on the demands and responsibilities of day-to-day life, when things get more taxed, it doesn't show that in a creative way, so that way we can kind of make the diagnosis fit the condition. And like we said, we're kind of looking at this in terms of what an average person anywhere in a small town would be able to experience. But then we have things as advanced as technology with eye movements that folks in the military are using to be able to detect blast injuries on the spot.
Yes.
Now, that's very specific technology, obviously very access oriented, but it does show that there's more effort being put into getting this caught sooner rather than later. But one scenario that's really tough to detect right away is in sports, because if somebody first gets hit, their symptoms might not evolve for several minutes or even a few hours later. And that's like a really decision to make as a coach or an athletic trainer, to know when someone just gets a bump on the head or a knock on the head versus they're concussed, and deciding whether to let them play on or not. So
now I've read somewhere that there was and I'll probably never be able to find it. I should have noted this for this, but there was something that came where there was a specific protein in your blood that was present for maybe 1 to 2 hours after the concussion. And then after that, it would go away. So that protein would no longer be existent or there would be more of that specific protein in your blood directly after your concussion.
Mm-hmm.
And I can't remember where I seen that, but
that's definitely on the more advanced technology side. There's even certain changes that happen right away with calcium release, and all of that would take a lot of know-how and technology on the spot that's just not globally available. But there is a ton of science and research that's been put into how do we catch this early and catch it correctly. It would be a shame to treat somebody for a concussion that doesn't have one.
Right.
But it's almost right now you're better off doing that rather than the reverse of that. But
not treating somebody that does have one.
Right.
Yeah.
So
it's better to have it and not need it than need it and not have it.
Yes. So in an attempt to make, again, something that doesn't require special technology, doesn't require a very specific skill set, they developed a sport concussion assessment tool. They call it a SCAT. And right now it's on version 6. But this was compiled based on a bunch of experts getting in the same room saying, how do we provide an objective way for an athletic trainer to be able to determine if someone has a concussion on the spot? And believe it or not, there's step 1, which is just basic observable signs, like are they lying motionless, are they seizing, all those things would let you know clearly this person needs emergency medical attention. Step 2 of that assessment is the Glasgow Coma Scale.
Gotcha.
So it made its way from the 1970s all the way up to present day to be included in this essentially sideline tool for people to know whether an athlete sustained a concussion or not.
So it's still there. They're not getting rid of it.
They're still there, because if you do score poorly on the Glasgow Coma Scale, guess what? You have a concussion. If you're only responding to pain, if you're not following motor commands, you need to come out of that game either way.
But this one, the new criteria that is being implemented is going to be a little more specific and be able to
more comprehensive. Yeah.
More comprehensive.
So then it goes on to be able to assess everything else that we know is going to be influenced by the possibility of a concussion. So it goes through an assessment of the player's neck, then it will go through their eye movements and coordination. Now, the coordination on this is just like a finger to nose test. It's not very sport specific or high level coordination.
Gotcha.
Then they look at their their memory.
Okay.
So
Their working memory.
So they call this set of questions the Maddox questions.
Okay.
And athletes, believe it or not, will either try to memorize these ahead of time or have a fellow player brief them on what the answers are right before they have this assessment with their athletic trainer, just because kids so badly don't want to be pulled from sports. So the Maddox questions are: what venue are we at today? Which half is it now? Who scored last in this match? What team did you play last week or game? And did your team win the last game? So what do you think of those questions? If you had just got hit in the head, do you think those would be a good assessment as to whether you've had a concussion or not?
I do. I think they would be. I think they're pretty good because they're really working on your memory, not only your working memory but your long-term memory. Because it goes like working memory, right? Is like remembering somebody's phone number really fast. Or if I say, hey, remember the number 321, and then I ask you a couple minutes later, hey, what was that number? And you say 321. That's like your working memory. That's like what is happening, and then that gets transferred over time into your long-term memory. And I maybe like next week I could say, hey, what was that number I said? 321. So I can see that those questions are really trying to like incorporate all that.
Yeah. So you're right that it does capture different points in time for that reason. Like, what's the score now? What half are we in now? Who are we playing against, or what's the venue? But then, what was the last game? Did you win? Where were you? So yeah, so it's taking things from more of an immediate recall or a working memory standpoint, and then forcing the athlete to think back more in their short-term or long-term memory. So they're pulling from different resources in the brain. But since they get asked so often, and in sports like football where you might take a lot more head impacts and they're used to having these questions asked, it allows the athlete to prepare or another player to prep you. So if you go down, and again, very competitive game, this person that goes down happens to be your star quarterback, one of the linemen could go up to him and give him that information very quickly.
Yeah.
So I don't think that that's a real reason why it gets skewed, but I just do know that that's anticipated by athletes, that they don't want to be pulled for any reason. And athletes don't know if they're concussed or not. If they do know, then they are probably
really concussed.
Yes. But at the time, they can't transition into that self-inventory role of being able to assess all of these things on their own. And their drive is just to continue playing on. So if that means having these answers prepared, that might be something they're incentivized to do. But then again, it goes around and then looks at the more global implications of these symptoms. So as you know, concussion is not just headache, right? It could be pressure, neck pain, nausea, dizziness, balance problems, sensitive to light, sensitive to noise. Like that whole symptom profile is included in that sideline assessment in the SCAT-6.
Gotcha.
So, and it does incorporate a little bit of the background that we mentioned that is using more current evidence to be able to assess the athlete. Like if the athlete's been diagnosed for ADHD, if they normally have headaches, what are they currently being medicated for, if anything? So all those things are now kind of included in the assessment. And then there's a cognitive piece to it, as if memory's not enough.
Yeah, now you got to do a test.
Yeah, now you got to think a little bit. There are similar orientation questions to what someone's asked in the hospital, like who's the president, what year is it, all that kind of stuff. But it goes into, what's a month, the date, day of the week, year. That kind of helps build a little bit more of a grasp of the orientation that might not be captured with just specific game data, like of who are you playing and who scored last. So that part's helpful. And then it gives immediate memory tasks. The example you gave of remember 321. So there's a list of words here that you can give the athlete, and then they have to be able to recite them back at certain periods of time. One is immediately, and then one's after a few other tasks have been given.
You're good.
The 321?
321. Boom. How about that, ladies
back
and gentlemen?
In the game right now.
Wow.
Yeah.
Abby's got a heck of a memory. We're going to test it in 1 second.
What's that?
We're going to test. We're going to do a cool memory thing.
Yeah? Right now?
Yeah, well, in a minute.
Okay. And then it'll go through concentration things, balance. So it's all to say that it's a lot more comprehensive and like actually looks at things that are more appropriate for what would happen after a concussion rather than just the are you awake or are you not?
Gotcha.
Yeah. All right. What is the memory thing that we're going to do?
All right. Don't look at my screen here.
Okay.
You have to close your eyes.
Close them?
Close your eyes, like cover your eyes, and I'm going to bring this up. I'm going to do this. And this might not work. It might work. It works with a certain amount of people. Okay. Okay, so we'll do this. Can't see that, can you? Okay. All right. You can open your eyes now. So go with me on this. What is 1 plus 1?
2.
2 plus 2.
4.
4 plus 4.
8.
Name a vegetable.
Zucchini.
It did not work.
What was I supposed to say?
So, like, I should have done more. I should have did it more. Let's do it. Let's try again.
Let's do it again.
Okay, we'll just cut that out.
Okay.
All right, so 1 plus 1.
2.
2 plus 2.
4.
4 plus 4.
8.
8 plus 8.
16.
Name a vegetable.
Carrot.
Okay, there. I knew I should have did more. I should have did one more.
How's this, first of all, how's this a memory test? And second of all, why did you have the carrot pulled up?
So I knew you were going to say carrot. I knew I should have did it once more. But so the way memories work in your brain, you don't like store them anywhere, right? Like
you don't have a filing cabinet?
There's not a filing cabinet. Or like these synapses are kind of responsible for, synapses and neurons are kind of responsible for recreating these memories. So every time you remember something, you don't pull it from storage, you recreate it in your head. So every time you create a memory, it's a little bit different, but you don't know that because you think you're remembering it exactly right. One of the reasons that eyewitnesses in court cases are so like not really relied upon that much because they're not remembering it right. But when you answer easy math questions like that, simple, easy math questions repeatedly, and you're so neurons that fire together wire together. So that means that since it's simple, carrot is a simple vegetable that people think of. I don't know why, but that happens.
But how'd you know I wasn't going to pick celery?
Because people don't pick celery. They pick carrot. You can try this on people.
I'm going to have to now.
You can try this on people tomorrow.
I will.
And
it's pretty cool.
And it does. It's kind of got to be like that. It's got to be like, 1 plus 1, 2, 2 plus 2, 2, 4. And it has to be kind of quick.
Okay.
So,
But they're always going to answer carrot when I say name a vegetable.
So, right. So
if you were to say name a fruit, everyone's going to say apple?
I don't know.
How'd you know this one? Has it been studied?
So the reason I knew this was I was like years ago when I was a kid. And this is literally when I became interested in the brain and how the brain works. And we were on a field trip to the Pennsylvania Renaissance Fair. And some teacher, he wasn't a teacher. I don't know who he was. Some guy on the bus.
This is way before the kind of regulations that are in place now. It's just some random guy came on your field trip.
I don't know who it was. If it was like a substitute or somebody's dad.
Just wanted to go to the Renaissance Fair.
Right. He just gets on the bus and he asked this and he does that. But he didn't do that. He did it a little bit different. He said, what's 5 plus 2 and 4 plus 3 and 6 plus 1? And he answered, and all the questions were 7, 7, 7, 7. And it was all simple. And then he said, name a vegetable. And then whoever it was said carrot. And he had carrot written down. And I was like,
was he a magician?
I don't know. I was like, that was the coolest thing I've ever seen.
Wow.
I remember
it all the way till now.
Yeah. Long-term memory. And I'm like, that is so awesome.
That memory survives a motorcycle accident in a coma.
Right. Yeah.
That really made an impression.
It did. And that's literally like one of the reasons that I've always been interested in like brain stuff and how the brain works. And like, that's why that's like my hobby. Like people can tell you, like Ange can tell you about like 1969 Camaros. And I can tell you about like brain cells and neurons and synapses and glia cells and
how to make somebody say carrot. Yeah.
Hypothalamic, pituitary, adrenal axis, and hippocampus and pituitary gland is the like top dog like of your endocrine system. Like that's interesting to me. That's like a 1969 Camaro to me.
Now, what if that guy was actually a magician and that was how he was trying to get people interested in magic? And you took away from that this brain thing.
I don't know. I don't know. I don't remember who that dude was.
But he wasn't a teacher.
I don't think so.
Was it the bus driver?
Wasn't the bus driver.
Man, back in the 80s or 90s, whenever random people could go on field trips.
That was in the 80s.
Now you got to like pass an FBI background check, get fingerprinted beforehand, have 3 references.
Yeah, that was in the 80s. That was probably, what was, I don't even remember what.
Did you go on any field trips with Destiny?
No, I don't think so. No, she would never go on field trips.
She would stay home?
Yeah, she's like, I don't want to go to that. And I'm like, what?
She didn't even have the courtesy to ask you if you wanted to go?
Right.
Because now we've realized field trips are actually for the adults. Guess we should wrap up here on our
We're back.
diagnosis of the concussion evolution, going all the way from the Glasgow Coma Scale to something more sophisticated in the SCAT-6, so that way we can be a little bit more comprehensive in how we detect concussions and then get people treated on a more timely basis.
Yeah. And this is breaking news, everyone. This is just happening. Like, you could probably ask some people about this, some doctors, and they may not even know it yet because this is breaking. This was like, I believe, May 20th. They started.
Oh, for that specific biomarker. Yeah. For being able to put things together in a more comprehensive way. But as we know, anything that's new is going to take some time to kind of trickle down to be more common practice.
10 to 17 years.
A while.
Yeah. Long time.
But thank you all for joining us, and we'll be back again next week.
Yeah, and there's no need to wait 17 years if you want the latest breaking information on concussions and traumatic brain injury. Be sure to check back next week because we'll have it.
Talk to you then.
See you.